So we're going to talk about medical complications of substance use disorder, and we'll get right into it. I have no financial things to disclose. So this is actually the bulk of the PowerPoint. Outside of what you have already seen, and my next slide, which is references, this is it. And so I gave this presentation for our behavioral health didactics a few weeks ago. And I like it because it goes sort of over, head to toe, some of the effects of substance use disorders. And as you'll see on your screen, I guess it would be stage left is the green part, effects of prolonged alcohol use, or from your perspective on the right side. And then on the other side is the yellow, and that's prolonged drug use. Now, obviously, there are a lot of things that overlap in terms of consequences of use that is the same for both drugs that are not alcohol and alcohol. But this one does break it down a little bit into more specific things. The biggest difference that you will notice between the two, which we'll start with, is the cancer risk of alcohol use. And so there are not as many outside substances other than tobacco, but the other substances that are frequently seen do not have as strong a tie to cancer risk as alcohol. And that is not necessarily to say that the risk is not present. It's more so to say that the association has not been observed and documented yet. A big part of that is the legal status of alcohol. So again, that's the big difference there. But we will start with the effects of prolonged drug use. And what I would like to do is just kind of go top to bottom and we'll hang out on a few different points a little longer than the others, but just sort of going through and getting all of these and talking just a little bit about some of the effects. And I wanted to do that instead of, really focusing in on, 2 or 3 complications and spending the entire presentation on those, just to get a feel for sort of the wide-ranging effects of substance use. So if we're going top to bottom, it all starts in the brain. As we see clinically very often, you'll see one of the primary changes and effects that you will see is impaired cognitive function. Now, I think it's important to note that the title of this graphic is long-term health effects of prolonged drug and alcohol use. And so when we think of impaired cognitive function, obviously, when someone is impaired, right, that's in the term itself, when they are under the influence of substances, they do have impaired cognitive function, but this is actually long-term cognitive function. And we see this for a couple reasons. We can see it as a direct toxicity from the substances themselves. And we can also see it as a secondary effect for things like, say, stimulants in particular. There is risk of ischemia. There is risk of killing off brain cells from that. Increased risk of stroke with stimulants. And so that would be a secondary effect that would cause impaired cognitive function. But there is, to some degree, direct toxicity on the cells themselves as well. We can see changes in memory and changes in brain connections. That's sort of a vague statement, but essentially the point of that is that what we know about the brain and our neurons and the connections that they make is that, just as a general statement, the more we use something, the stronger that connection grows. And so we will have more myelin in those areas, and so it's more insulation for the connection, and so the connection runs a little faster, and that in turn reinforces the connection. And so the more we use something, the better it works, just as a general statement. Well, with addiction, what we see is this binge intoxication withdrawal cycle. And with that, there is just this complete roller coaster of intoxication and withdrawal. And so what that does is it affects our dopamine levels to the point where our dopamine is on a negative feedback loop. So as we're flooding our brains with exogenous amounts of or exogenous causes rather of dopamine, which is much more dopamine than our brains were designed to handle, our brains in turn will downregulate our dopamine production over time. And so when the exogenous source is withdrawn, we're actually at lower baseline levels of dopamine. And what that process of intoxication and withdrawal can do is it reinforces our limbic systems, the fight or flight, the sympathetic nervous system. It reinforces all of those survival mechanisms. And this is, at least in part, responsible for a lot of the behaviors that we typically see with addiction. When we think of behaviors like theft or lying or things of that nature, a lot of that is it's survival skill. And so the part that is most likely to get down regulated due to lack of use is the frontal lobe. And so that's why we see quite often in chronic use disorder, we'll see the frontal lobe and its associated functions get significantly downregulated, and it can take a significant amount of time, typically a couple years is kind of the benchmark, without use for that to be restored back to some degree of normal function. And so these are some of the most consistent changes that we will see with chronic use from a brain standpoint. And then of course depression, anxiety are linked. There is certainly a very close association between depression, anxiety, and substance use. Obviously, this is not entirely causative. A lot of times the use will be spurred on by the pre-existing anxiety and depression, but there is a lot of anxiety and depression that can be caused from use and from the consequences of use as well. We see paranoia on there as well. Very common with stimulants. You hear that a lot with cannabis or THC in particular use. And also with other substances, right? So there's not just the substance causing paranoia, but there's also the social construct of use. And so if people are using things that are illegal, right, there is a paranoia surrounding that as well. Oftentimes not a pathologic paranoia. A lot of times it's just, I'm scared and I have very good reason to be scared, right? So those are some of the more common effects that we see. And then starting kind of up at the top of the list itself, so we're not necessarily going head to toe. We started with the head, now we're going according to the list. So the first thing that's on there is kidney failure. Again, we see this sometimes as direct toxicity. Although if we're thinking about direct toxicity of substance use, the liver is the more common thing. With the kidneys, a lot of times what you'll see is dehydration. And so we'll see kidney failure due to that. It also can be secondary, tertiary cause, right? So if someone has an acute illness, like an infection, right, that causes sepsis, which causes kidney damage, that can be a downstream effect as well. Liver failure is a common issue, and this can be either direct toxicity as well, although liver failure due to direct toxicity is much more common with alcohol use than with other substances. But the other thing that we will see liver failure from frequently in substance use is due to infectious disease. So hepatitis C chronically, the other hepatitis, particularly hep B, is responsible on occasion for a more acute liver failure. You can see gastrointestinal damage. And a lot of times this is, so when we think gastrointestinal, a lot of times that's in the upper GI system. So we are seeing things that are toxic to the stomach itself. And then I will, even though it's a little higher up, right, we're also thinking oropharyngeal, right? And so if, depending on what substances people are ingesting by mouth, you can see direct effect on the oropharyngeal system, and then also with the stomach as well. And so there's not a typical thing that's directly toxic. The other big thing from a gastrointestinal damage standpoint that we see a lot of times is opioids causing constipation. And we think of that as being more of a nuisance than anything, but it can be fatal. And it can reach the point where people are coming in with stercoral colitis, and having really significant, they can have bowel obstruction, they can have bowel perforation, and it can be really, really significant. And long-term heart disease is a common thing that we would see with stimulants. Of course, they directly act on the heart through catecholamine release. So just the effect of sort of overstimulation, right, over time is an effect of that. We also can see effect with endocarditis if there's actual valvular damage there. That's a potential issue from particularly IV use. Heart failure, again, stimulants are the more frequently associated cause of heart failure, but if there's valve damage from IV use, that is a possibility as well. Collapsed veins, very, very common. And then infections, this says in blood vessels or heart, I would add skin, soft tissue infections. We're actually talking about what's most common. That's the most common. And it can be significant as well. You'll see a lot of abscesses. There will be a lot of cellulitis, staph and strep. But then also you can see other bacteria there because it's very dependent. We think staph strep just because it's on the skin and they're a bit more ubiquitous in the environment, but also people mix their stuff with all kinds of stuff. And so if they're using some water source that is not clean, there's any number of things that could cause infection from that. And then of course, if the infection spreads to the heart, then you get infective endocarditis, which can cause some of the effects which we've already talked about long-term, the heart disease, valve issues. From a respiratory system standpoint, lung cancer doesn't necessarily matter what the substance is, right? Our lungs were not designed to breathe in things that are not air. And so if we are breathing in, whether it is tobacco smoke, whether it's a vaporized substance, smoking things it's not good for our lungs, right? And so all of these, the lung cancer, emphysema, chronic bronchitis, and asthma, all of that, that's kind of the idea behind it, right? If we're smoking something, it's not good for our lungs. And so you can see any of these issues from smoking really any substances. On the alcohol side of things, we do have, in terms of effects on the brain and cognition, we do have some more, I guess, classically understood syndromes from that. And a lot of that is, again, like a lot of the issues that we're talking about, some of that is direct toxicity, and some of that is going to be secondary effects like nutritional from thiamine deficiency, things of that nature. So it can be directly toxic, cause diminished brain matter. You can see, um, you can see matter loss, right? Memory loss, loss of attention span. It can cause difficulty learning, and then Wernicke-Korsakoff, right? So thiamine deficiency causing dementia, causing basically shrinkage of the mammillary bodies. And so that's with chronic use, and nutritional deficiency. Personality change as well. Again, a lot of these things that we see, we think of them in the acute setting, right? If you go, okay, memory loss, loss of attention span, change in personality, that kind of sounds like someone who's inebriated, like currently, right? But a lot of these can be persistent effects with chronic heavy use. And then I don't know about y'all, for me, at least thinking back years ago, if you were to ask, what bad things does alcohol do to the body? I'd pretty much go, I mean, I know that there's more to it, right? But you think liver and pancreas, those are kind of the big ones. And so we will start with the liver, right? Alcoholic hepatitis is a very common cause of chronic liver damage throughout the world. That is direct toxicity. And that's something that is seen with chronic heavy use, can progress to fibrosis and cirrhosis, which of course can cause any number of issues. And there is a point at which that process becomes irreversible. The good news is the liver itself, very hardy. It's pretty good at fixing itself if we give it the ability to do so. But chronic heavy alcohol use kind of impedes its ability to do that. Alcohol can cause high blood pressure, which in turn can lead to stroke, right? So chronic hypertension is a direct risk factor for stroke. And then alcohol itself can cause stroke directly, not just, we think of this more so in the hemorrhagic stroke, right? So if we're thinking about chronic hypertension, by and large, the downstream effects of that are going to be ischemic stroke, because ischemic strokes are much more common than hemorrhagic strokes. But the high blood pressure and the alcohol can cause hemorrhagic stroke as well. Alcohol acts as a blood thinner, in large amounts, and so it can make bleeding worse, make hemorrhagic stroke more likely. Irregular heartbeat, classically, this is AFib. Alcohol use is highly associated with AFib. It is very common. A lot of us have heard of, what they call holiday heart, where somebody goes and drinks a bunch of alcohol, and then all of a sudden they're in a weird rhythm, typically AFib. And so that is a known risk factor for AFib. Ulcers, again, direct toxicity, right, from the alcohol itself. And then secondarily, if someone progresses to cirrhosis and they begin to get dilation of all of the blood vessels leading into it, it can cause varices, it can cause bleeds in that sense, and can also make the ulcers worse, but also it can cause direct toxicity to the stomach tissue, cause gastritis, and then eventually ulcers. Pancreatitis is very common. Alcohol and biliary causes account for over 70% of the acute pancreatitis that is seen. And so alcohol is a very, very common cause of pancreatitis. And pancreatitis is not just a pain condition. Typically, it's going to present as a painful condition. That's what we see. We'll see vomiting and pain. And so the way that we treat that typically is we will nourish someone not by mouth, although we're moving more toward early feeds. It used to be that we would keep them NPO for a very long time, and the idea was we're letting everything heal. Now we are moving toward feeding as early as they can tolerate. But it's not just a pain condition. It's one of those things that is very routine until it's not. And so pancreatitis, you can get infective pancreatitis, which can lead to sepsis and death. And so it can actually become infected. And of course, we're dealing with, within the intra-abdominal cavity. And so you can see a lot of, you need significant antibiotic coverage to cover all of the potential things that could grow within the intra-abdominal cavity. And then you can also get, pancreatitis, by definition, it's essentially auto-digestion of the pancreatic tissue. And so if you have that happen enough, particularly with recurrent pancreatitis can essentially turn someone functionally into a type 1 diabetic because they don't have enough pancreas left to make the insulin that they need. And so there can be a lot of significant effects from pancreatitis as well. Alcohol use can cause reproductive health issues. This is in both men and women. It's highly associated with erectile dysfunction, which of course is a reproductive health issue. It can cause menstrual irregularities. And so there's a lot of concern there. And then also can cause osteoporosis. From a cancer standpoint, alcohol is linked with a fair number of cancers. All of these cancers that are listed in addition to, I don't see stomach on the list, which is interesting. It's also associated with stomach cancer. But all of these associated cancers have at least a decent degree of association, right? Now, there is determining causation in things like cancer can be very, very hard to do just because of the nature of it. But there is very strong association between alcohol use and all of these cancers. And the other thing that's not really on the list because it's the long-term health effects, but there was a great study that came out, I believe 2 years ago, or very early last year, maybe, studying alcohol use and all-cause mortality. And historically, we've thought of alcohol use as sort of having this J-shaped curve in terms of risk of mortality, where if you just drink a little bit, right, your risk goes down, because it's good for your heart and things like that. And then as use increases, it goes up, and that's your J-shaped curve. And what this study found that was very good, and I will send it to whoever I need to send it to get it on the website to link that study. I believe, I can't remember, I believe it was in New England Journal, but I don't recall. But what they found is essentially there is no J-shaped curve with all-cause mortality in alcohol. It's just linear. And so the more alcohol use someone has, the higher their risk of mortality. And that's through a variety of reasons, of course, cancer being some of them. That is, let me see. That is my presentation. Here are my references. Any questions, thoughts?
I do know in your comment about the J-shaped curve in alcohol, there, there was a lot of consideration that the alcohol may not be causative but associative. That being that people who imbibe moderately, they may have other habits where they do moderation, and they may have other issues that are concurrent with the low level of alcohol use, but that may not be any. It may not be the alcohol. It just may be that they do other things as well in moderation, which is good for you. You know. Anyway, that was the thinking for what it's worth.
Yeah, at this level, anything causative, right, is very, very difficult. Because people are complex and life is complex. And so when we're trying to take these very, very complex issues, let me see. That might be the study I was looking at, although I was thinking it was newer than that, but it may not be. I'll keep looking for it and see.
That was the original one that like blew up the J-shaped curve. So you
Yeah,
maybe
okay. So this might be one. I'll have to look at it and see if that's the one that I thought it was. So yeah, so talking about causation, right? We're trying to take complex things and boil them down into, okay, well, what made this happen? And you know, as scientists, we don't necessarily always want to hear this, but by and large, like you just can't do that with life, right? There are some things you can do that with, but for most things you can't. And so, yeah, there's always going to be a question anytime you have associations like this, even if it's a very strong association, there's always a question of, well, okay, is it actually causative?
Yeah, another
One
thing is,
comment.
yeah.
Go ahead, Cameron.
Well, I just want to say that one of the biggest, also factor on this would be that the neglect that is happen as a result of the use of the substances from both sides, from the patient side, the person that is using the substance, and from the, all the barrier that it exists for getting to the treatment if they need to get evaluated. So that increases the mortality. If I'm not going to the doctor because I am always, using substances and I neglect my own, body, therefore they may catch the problem late enough that it increases the risk of the mortality. So looking at it from the biopsychosocial approach, you see that the most of those patients that they do have a substance use, they neglect their body themselves too.
Yeah, I had a similar comment based on, and a lot of this was in my lecture last week, but keeping in mind how these, medical comorbidities are actually impacting the actual level of care that our patients able to obtain, regardless of what they may need on paper. It may be hard to get them certain levels of care. For example, our patients that are, wearing oxygen, or they're homebound, or in a wheelchair. These things are things that can't necessarily be accommodated at some levels of care. For example, residential care, a lot of times that could be very difficult. Or if somebody has acute or chronic cognitive impairment, right, it's going to be really hard to get them to engage, like in group therapy or in psychotherapy, regarding treatment for a substance use disorder. So that would affect either your inpatient or your outpatient methods of treatment. So just keeping that in mind is important.
Yeah, we regularly have patients who would be good candidates for a higher level of care, and then you send them there, and as soon as they walk in, they're like, no, you go to the emergency room. Like this, I had a patient recently. I didn't see them in clinic, it was a hospital consult, but they had come in after being hit by a car as a pedestrian, and had multiple cervical fractures. They were in a C-collar. I mean, things were stable. They didn't do surgery or anything, but we talked to our local inpatient facility about them, and they were basically like, can't guarantee we can take them. They wouldn't tell me no, but they couldn't guarantee. And so that, things like that really impact the care that people are going to be able to get.
I definitely have that struggle at the inpatient detox. I have to fight that battle often because, in my opinion, if you're stable enough to be released from a hospital home, technically we are a higher level of care, but that is not how everyone sees it. So I'm often trying to navigate that just to get people into detox. And some I win, some I do not.
In my experience, also there is lots of detox needs to be done on the medical floor instead of the psychiatric department, based on the really outcome needs to be better to be on the medical floor. But in my experience, most of the places I worked is they usually refer the detox to the psychiatry instead of the medicine. And I don't know what is the problem, but I assume that it's a little bit of the lack of the education of the people that they are working on a medical floor to take that initiation and learn that detoxification process, and some behavioral problem that happens during the withdrawal and during the detoxification that they cannot manage it on a medical floor, that would rather to do it on a psychiatry, and that increases the risk of the patient not being accepted in a psychiatry unit when there is no special unit for the detox on that psychiatry department.
Does anybody have a specific patient that they'd like to talk about that they have treated with long-term effects of either alcohol or drug use? Because I don't think we have a case today.
Oh, I have multiple patients with infective endocarditis, and that could be a significant challenge, or really any infectious complication that often requires long-term IV access to treat. That can be a really difficult situation that we not infrequently run into, and I'm guessing you guys do as well. But a lot of factors go into determining whether these people are able to go home with some kind of access or pick line or something like that. But that could be a really difficult, challenging situation. And in one hand, you're kind of darned if you do. If you don't let them go home, they stay in the hospital. They might leave AMA for whatever reason for weeks and weeks. They rack up a massive hospital bill. But you can be darned if you don't too. A lot of physicians are worried about the liability of people using the lines incorrectly, misusing them, injecting drugs, etc. So that can be really challenging. Part of getting somebody treated. Additionally, there aren't a lot of treatment programs that'll take people that are, again, medically complicated like that. It'd be hard to get somebody like that to a residential program. There are specialty programs that exist, but none in our area that I'm aware of.
Yeah, I can say in our area, either with the medically compromised people, we have very limited resources at the treatment centers that we typically refer to from detox. I think they have one handicap room at one of the treatment facilities, and it's usually always full. There's a wait list, and we can't keep people for a long time. So it definitely presents a challenge here as well.
So I have a memorable guy I remember from when I was on internship that I got sent from inpatient medical because he had like his third heart attack in like rapid succession from crack cocaine use. And he's in his probably mid-50s. And it was just, if he kept using, it was going to be, the next one was potentially going to kill him. And the physicians were just like, make him stop. And I was like, I can't, like, it doesn't work like that. And we tried, but he didn't want to. He was okay with it. He understood, the consequences, and he was, was more interested in continuing his substance use than the risk. Like, he knew it was going to kill him. And I just kept getting like angry notes being like, make him stop. And I'm like, I can't. And I wish I could have, but he don't want to. And he understood, he wasn't cognitively compromised or anything like that. He knew what he was doing. It was a really hard case.
I think that's patients that have medical illnesses and injuries. I know when I was working in the emergency department and we had a veteran that came in, a young man, and he found his kid and he shot up some methamphetamine with this rusty needle, and his white count was 32,000. And the thing that you talked about where physicians say, make him stop, a lot of substance abusers, they are met with anger from the healthcare professionals. I think a lot of healthcare professionals may not understand the unfortunate situation that they're in. I think a lot of times the patients themselves may be angry at themselves, they have that feeling of shame, those sorts of things. There's such a complex set of psychological circumstances that go along with substance abuse, other self-injurious behaviors. And it is a big challenge. And I know I've heard people joke about somebody just got their cath and they're not in the ICU, they're down there smoking in front of the hospital, and people can't really get their mind around, why would someone do that? Maybe not realizing the biochemical effects that are going on and the complex things that go into decision making and the biochemistry of addiction. And people are very hard on patients that have substance abuse and health issues as well. We all see it, and it's an unfortunate thing, and it definitely doesn't help with patients' recovery. But it does point out the frustration of what do we do with someone, we want to help them, and sometimes patients seem like they're their own worst enemy, and of course they may recognize that as well. And I know a lot of people that suffer from substance abuse and addiction, they feel so trapped, and they realize the trap that they're in, and it's a major trap. It's not to be underestimated, and that's coming from someone that's not a mental health professional and should be quiet in the middle of mental health professionals who know so much more about it than I do.
I
No,
think
you're right.
there's a lot to be done as far as education goes. If you have an opportunity for interaction with medical students or residents, or even fellows who be taking care of patients, we're all going to encounter them no matter what our specialty is. But if you have the opportunity to intervene and educate that addiction is a disease, that's where we can start breaking the stigma that is associated with patients who have substance use disorder going in for general medical care.
Yeah, the breaking that stigma is very important for patients and for the medical field, staff, and society in general. That will improve the outcome of those patients, and they may get to the recovery faster, and they may invest more money to really help those patients as well. I mean, we see that pattern happen for the diabetes for a long time, and diabetes is not a shameful, disease anymore. And the patient, may have a higher, A1C for a long period of time, but no physician would blame the patient for it. And that can happen for the substance use as well. And hopefully that happened in my lifetime, but that is the goal, is to educate the younger people that they're coming to the field, as well as our communities to help. And also the patient self-stigmatized behavior can also prevent them from reaching out and getting help. We need to educate our patients as well. And I think that one of the things that Caleb was talking about, the effect of the substance on the brain from a psychiatric point of view, in cognitive impairment and also frontal lobe kind of the impairment of the functioning, would prevent them from really understanding sometimes that what is the damage. So we just have to simplify and be able to use as much as layman language in our communication to inform the patient that what is going on. So those are something, it comes to mind when looking at it.
Anything else? We've had a few people join us, so we have a few more introductions to make while you all can think of last minute questions or comments. Katie, can you unmute and introduce?
Hi, my name is Katie Langley. I'm a psychiatric nurse practitioner in Boone. Thank
Hey,
you.
Katie, it's great to have you. Good to see you.
You too.
Samia.
Hi, good afternoon, everyone. I'm Samia, the Addiction Medicine Fellow at ETSU.
I love that background. That's great.
Thank you.
And I think Onyeke is with us today. I think I said that right. Onyeke, if you're having trouble unmuting, you can always introduce yourself in the chat. That way we'll have record of your attendance, but I'm glad to have you back again today. Does anybody have any further questions or comments?
Just want to inform the newcomers that there is going to be a 1-800 number in a chat that they put it up there, that if this is the first time you are participating and you would like to get your feedback in and also get a CME for this participation, you can send your email address to that number and it will be registered, and then you can enter the code of this event and get the 1 CME. Of course, you will get an email in order to fill up your feedback, and then after that you would get your certification for 1 hour CME.
And we really appreciate the feedback we get through those questionnaires. It does help us plan for future sessions. So if there's a topic that you're interested in, be sure and put that on your questionnaire and we'll try to add it to our list of things we're covering.
I thought of one more thing in the silence that I wanted to add, kind of a summary of Cameron a little bit, is the mental health complexity of this, like trying to recover and now then, or maybe not even being ready to recover, kind of feeling hopeless about your recovery, substance use, and then having like medical complications add on top. We see high rates of like suicidal ideation in these patients. So make sure, like, if this is happening, like suicide screening, like this group does kill themselves, because it just seems really, really, really hopeless. And if we can, like Dr. Osborne said, like he's got lots of strategies to help people's health and to feel better, and we have lots of stuff on the recovery side that we can help. But this, like, sometimes when it all comes together, it just feels like there's not that future there to be more things worth staying for. So do the suicide screening.
we were discussing the suicide screening in didactics this morning and how even some simple problem solving can lift some of that load and make things not seem so heavy anymore. And like, you know, they can go a little farther. They can carry that weight. It's even if it's just a little less. So well, if nobody has anything else, we're getting close to 1:15, so I'll give you a few minutes back, and we will see you on the 21st. Same bat time, same bat channel. And if you need us for anything, you can reach the hub team through the website at any time. So thanks for attending today. Bye, everybody.